All right. We are live. Yes. Chapter 9 of your Hartman book, Nursing Assistant Care, the Basics. What's this version? 6th edition. Chapter 9, we're going to talk about rehabilitation and restorative care. We are on page 235. All right. All right. So we're going to discuss rehabilitation and restorative care. All right. Now, when a resident gets sick, a lot of times they stay confined to bed, they stay in bed, or the resident maybe they had surgery and they stay in bed for a very long time, and the resident is not able to do the things they used to be able to do, like walking and this and that, walking, running, taking care of themselves. Okay, so rehabilitation is necessary. Okay, rehabilitation is the care that is managed by professionals. So that requires therapy, physical, occupational therapy, nursing, etc. Okay, it helps to restore a person to his or her highest level of functioning. Okay, so what is the goal of therapy? The goal of therapy is basically, it involves, first of all, it involves helping the resident move from illness, from disability, from dependence, to having good health, ability, and independence. The goal of therapy is to help the resident regain function, to recover from the illness, to develop and to promote a resident independence, or to help a resident feel in control, okay, of his or her life. Sometimes therapy is only there to help the resident accept their limitation or their disability. Okay, rehabilitation will be used for many people, okay, for many residents, particularly those who suffered a stroke. A lot of times our residents suffered stroke, okay. They had maybe car accident, or they had an operation where they did a joint replacement and stuff like that. Okay, so rehabilitation will help them to regain function, because after surgery they stay long in bed long enough, their legs don't respond the same way, their arms don't respond the same way. Now, when a patient needs therapy to recover, they need rehabilitation. They also need restorative care, which usually follows rehabilitation. The goal of restorative care is to help the resident achieve their highest level, okay, of function. All right. It works to maintain a resident functioning. Okay. It helps to get the resident to stay at a normal level of function. So on page 235, we have some guidelines. Now remember, when you see the words guideline, that means you must study that area. Now, what is a CNA to do for a resident undergoing either physical or restorative care? Well, you have to be patient with the resident. Sometimes they're training the resident to walk again, to become independent, to put clothes back on again by themselves. So that takes time. Progress may be slow. Be positive. Be supportive. Be patient. Turn your book to page 236. Focus on the small tasks and small accomplishments. You may have to break steps down into small steps. All right, break the task down into small steps. Yes, setbacks can occur. However, you, the nurse assistant, you must be what? Sensitive. You must show and give the patient some encouragement. Encourage the patient to be independent. Whatever the resident can do for themselves, you encourage them to do. Yes, privacy is important, okay, when it comes to restorative care and rehabilitation care. Okay, so the nurse assistant is very important to the patient when it comes to rehabilitation and restorative care, because whatever they start in therapy, we have to continue it with them. All right, and there are times when physical therapy, occupational therapy, they will train the nursing assistant to continue doing work with the resident. Okay, so during your activity with the resident, part of your job is to observe and report. Observe any increase or decrease in ability. Observe any change in the attitude, any change in motivation, any change in general health, any signs of depression. Okay, so you have to keep an eye on the resident, on what's going on, so you can report any changes that's going on in your patient's health. Okay, so our job is to help the person become independent during rehabilitation. Okay, so we have to encourage the resident to continue the activities that they started in therapy. If therapy says is training them to walk, the nursing assistant's job is to help the resident do a little bit of walking, do a little bit of moving around, maybe changing position. Okay? Now, when the patient does not move around, when we don't do our job, when we don't encourage the resident to become active, to transfer from bed to chair, to do a little bit of walking, to do the range of motion that they taught the resident to do, here's what's going to happen. Page 236, loss of self-esteem. So the patient is becoming depressed, anxious, bored. They may even develop pneumonia, urinary tract infection, and the list of problems continues. But when we encourage them, when we do the therapy, the resident has better quality of health. They improve better quickly. They have better circulation. They become stronger. They can sleep better, relax. Mood is better. Self-esteem is better. All right? So this is when we are involved in activity with the patient, in helping the patient become active. And we help the patient do certain things. Okay? Page 237. Okay? On page 237, part of the activities, some of the activities include ambulation. Ambulation means moving and walking with or without devices. So part of the job is to help the resident walk. Sometimes walk to the bathroom. Sometimes we help them walk to back and forth a little bit. When your resident had surgery, the doctor says after 2 days, we need to get them to walk a little bit. Okay? So sometimes the walking can be with a cane. Sometimes the walking can be with a walker. Okay? Now, you definitely need to use a gait belt, all right, to help the patient with walking. Okay? The word ambulatory means able to walk. Patient is walking. Okay? Now, we do have a video on assisting a resident to ambulate. Part of your state exam is to assist a resident to ambulate from bed to wheelchair using a gait belt. So, are you going to watch that video? Yes or no?
Yes.
Yes. Okay. You have to play an active role in your education. All right? Because that's going to help you more. Okay? Listen to this. A very rich man said this. Now, if a rich man start talking, you need to listen. Okay? A rich man says education in the classroom can make you money to pay your bills. But education you do at home by yourself can make you a multimillionaire. Okay? Anybody here want to be rich besides me? So you don't want to be rich? That's a lot of money, right? So if you educate yourself at home by yourself, instead of TikTok, Facebook, Instagram, and all that nonsense, if you educate yourself on your own time, believe me, you will not regret it. So you watch that video on ambulation. Remember, privacy is important for your patient, so you want to close the doors, right? Pull curtains and whatever you have to do. Remember, safety is important. You're going to need the gait belt, right? Non-skid shoes or footwear, right? You're going to need to dangle. Remember what dangle means?
Yes.
Patient is sitting at the side of the bed, feet touching the floor, and you ask the patient one important question with it, which is,
Dizzy.
yes. Do you feel dizzy? No. Now we can get up. Patient says they're dizzy. Guess what we say? Let's go back down and lay back down. Right? When you're getting the patient up, remember good body mechanic? Lock your knees against the patient's knees. Grab the gait belt. Keep your arm close to your body and bend with your legs and move up with the patient at the same time. And you ask the patient to push against the bed as you get them up. Very good. And when your patient starts to walk, go to page 238. Remember, you have to have your hand, your right hand, on the patient's gait belt from the back, and you're standing on the side. The CNA stands on the patient's support, the weak side, right? As the patient hang on to the cane with the strong side. Okay? So, page 238. Okay? After the ambulation, return the resident to the bed or the chair. Now, people don't pass their exam when they don't remove the gait belt and make sure the patient is comfortable. So you got to remove the gait belt, make sure patient is comfortable, and give them back the call light. Okay? And then complete your finishing up steps. Okay? Complete your finishing steps. All right? Page 238, that cane that you are seeing there is called a quad cane. Okay? It has four rubber tip on the ground. 4. Okay? Quad has 4 tip. Okay? Now we got different types of cane. There's the C cane, okay, the functional grip cane. The C cane is a straight cane. etc. But the thing about the cane is that you can adjust the height, okay, of the cane. Now, yes, we do have a video on ambulating a resident with a cane. Part of what the nursing assistants will do is, when you work, is ambulate a patient. If the patient can walk, we don't put them on a wheelchair. We don't put a diaper on and say, go ahead, pee in there, and I'll change it. No, I can walk. So let me walk to get to the bathroom. Okay? And your job is to assist me as the resident. Simple as that. Okay? So we can adjust the cane height. Same thing for the walker. Okay? Or the crutches. Now we have a video on assisting a resident to ambulate, assisting with ambulation for a resident with using a cane, walker, or crutches. Again, spend a little bit of time with that video. Make sure the cane or walker is in good condition. Make sure the resident is wearing securely fastened non-skid shoes before ambulation. All right. When using a cane, the resident should place the cane on the strong side. When using a walker, have the resident place both hands on the walker. The walker should not be overextended. Stay near the patient, but stand on the weaker side. Don't hang purses or stuff like that on the walker. Okay, adjust the height of the walker or the cane or the crutches. So on page 239, you have the steps on ambulation using the walker, cane, or crutches. Okay, now go to page 240. Okay, when your resident is using cane, walker, or crutches. All right. When the resident is using cane, walker, or crutches, basically what we do is we have the resident hold the cane, walker, or crutches on the strong side. Please take a seat. I'll be with you in a few minutes. We have the resident holding the cane, walker, or crutches on the strong side, okay? And as you watch the video, you will see what goes down first and next, okay? All right, so go on page 240. You will see we call these things, assistive devices. Assistive devices many devices are available to help people who are recovering from or adapting to a physical condition. These devices, we call them assistive devices. The cane is an assistive device. The walker is an assistive device. If you look on page 241, you will see they have special forks, special plates, special cups, special combs, right? If the person has different disabilities, different types of problems, okay? Especially problem with the grip with the hand, okay? Because if the hands is crooked, if the fingers are crooked, they create a spoon that we can place in the patient's hand like this, and the patient can use that to feed themselves. All right? They create a special comb that you can put the handle in the patient's hand, and then the patient can use it to comb their hair. We try to encourage the resident to become more independent. Okay? Now, having your patient in good body alignment is key to prevent pain. Having your patient in good body position is key in preventing pain and discomfort. So on 241, you see that we also use a pillow, multiple types of pillows to help the patient be more comfortable. Okay? If the patient is laying on the side, we have pillows between the legs, under the arm, right? Behind their back. A lot of times we would have a towel that we roll up and we put inside the hand because the fingers are contracted. So we want to open it up and put a towel in there. Okay. We have patients that have other types of assistive devices, can be called prosthetics. If your patient had amputation, we chopped up a leg, they lost a leg, all right? Now, these patients they will experience phantom pain, okay, or phantom sensation, meaning the area that is cut, right? They feel pain in there, even though the limb is not there. All right? So we call that phantom sensation and phantom pain. So a lot of times what the CNA will do, if they don't understand what's going on, they will say this patient is crazy, imagining things. But the fact of the matter is, if the person says they're in pain, they are in pain. Even if you have a part missing. So they cut up the leg, right? So or let's just say take the arm. They cut the arm. The right arm is no longer there, but the patient says, I have pain in the right arm. You know why they have the pain? Is because nerves that would go to the arms is still left in the body and they can sense pain. So the CNA is going to report those pain, okay, as if the pain is really there, because it is there, okay? So we would ask the same old questions. Where is the pain? When did it start? How does it feel, etc.? And then we would report that to the nurse. Those patients, they would use what we call prosthetics. This is a device that would replace the body part that is missing or deformed due to surgery, accidents, etc. Okay? So here's what the nursing assistant's responsibilities are. Okay? If a resident had a body part that has been amputated, okay, your job will be to help the resident with ADL care, all right? And also help them to adjust the prosthetics the way it should be adjusted. And they will teach you how to put it on. That's fine. You learn. Okay? Your education continues after you leave the class. When you take a job somewhere, they will train you. If you're sitting during training and you're not interested, they can tell and they say, well, guess what? We'll call you. Don't call us. We'll call you. And you know what that means? You don't have the job. Okay? So they will teach you how to use the prosthetics that the patient use. Sometimes the prosthetic is an extra arm, is a artificial arm, artificial leg, artificial eye. Okay? All of that is part of prosthetics. Okay. We have other activities that you will be trained even more. Now, in class, we practice this. It's called range of motion. Exercises that put a joint through its full arc of motion. So, the goal of these exercises is to make sure that your patient don't remain contracted. We want to move the joints so it remains flexible. We have a video on range of motion that I want you to make sure you go watch and you study those expressions: abduction, adduction, flexion, extension, dorsiflexion, rotation, pronation, supination, opposition. Now, you have the picture of what they look like. You have the video to watch, but you got to do what? Practice. Because if you don't practice, you don't remember it. That's why when you do CPR with me, I make sure you do a lot of hands-on when it comes to the compression, because I want you to remember. Okay? Now, range of motion, we have 3 types of range of motion. There's active range of motion. Active is basically the patient doing it on their own. Active. They're actively doing it. Passive range of motion, patient cannot do it, but you do all of it for the patient, like someone who had a complete stroke or someone who's in a coma and whatnot. And then there's active assisted range of motion, meaning the patient starts to do it and you're assisting, you're helping. Okay? So, between page 244 and 245 to 46 to 47 to 48, all the way up to 249, you have all the range of motions. Now, not only do you need to go through the reading and the video and doing the practice, I want you to know that on the list that I give you, on the skills that's going to come up on your state exam, they may want you to do range of motion of a particular body part, like the shoulder, or range of motion of the right leg. Okay? So you got to write down, take some notes on flexion, on extension, on all the different moves. Okay? Call your husband, call your kids, and practice on them. Practice the range of motion on yourself. Okay? The only way you're going to remember is if you do it. Okay? So range of motion starts from the head all the way down to the foot. Okay? You got rotation, moving the head around. You got flexion, extension. You got flexion, extension, rotation of the shoulder, abduction and adduction. You got what we call supination and pronation. So again, I can pronounce all those fancy names, but if you're not taking the time to practice this, that's not going to work for you. And you need to take a few minutes to do the hands-on practice. Okay? So your true education starts when you leave the classroom, you get into your bedroom, you close the door, okay? You tell the family, look, I'm not cooking today, I'm studying. You guys can eat McDonald's, Burger King, whatever, I don't care. I am studying. Okay? So, let's go to page, I know, right? See, some of you think the education is here. No. Here, I introduce you. But the true education is when you're at home, right? And then you open what? Not the fridge. You're opening the wrong thing. Open the book. Okay? What is it? Once you get your food out of there, stay away. Open something else. It's called, no, not that, the book. Okay, open the book. Okay, now let's go to page 247. So you did range of motion from the head to the shoulder, to the arm, to the hip, of the right, of the legs, of the knees, of the foot. You do all of that. It's 11-minute video. You can watch it and practice it as many times as you want. You're going to be doing this for people. If you do it wrong, people get hurt. Okay? Good. Now, page 247, we help the patient with bowel training. Now, we went over that on chapter 6. Bowel training, basically, this is us helping the patient regain function of their bladder and bowel. Okay? So what do? Well, we follow standard precaution with wearing gloves, hand washing and wearing gloves, and wearing all the PPEs necessary, right? We explain the procedure to the patient. I'm here to help you to the bathroom. Simple as that. Okay? Keep a record of bladder and bowel habits, so you keep an eye on how often the patient goes to the bathroom. Offer bedpan. Go to page 248. Encourage the resident to drink plenty of fluid. Encourage the resident to eat food that's high in fiber to help them control their bowel. Answer call lights. The job is not just to clean the patient. If you're not answering the call light, your patient may die on you and you will never know it. And you will have some explaining to do. Okay? Bladder or bowel training has to do with developing a schedule that your resident body will get used to, and at this point your resident can, 8 a.m. patient is going to go to the bathroom, 11 a.m. again, 2 p.m. bathroom, 7 p.m. bathroom. It's just like when you're teaching a child to stop wetting the bed, right? So that is what it's like to have to prepare your patient for bowel training. Okay. A lot of times you may have to change the patient's brief, okay, and or take them to the bathroom. Don't show frustration. Don't show anger. Show compassion. How many people are here because you want to help people? Do you want to help people? Yes. If you're here just to make money, believe me, you're not going to last too long. You got to love helping people. And when a person put on the call light because they need to go to the bathroom, you're going to remember, I'm here to do what? To help. So you do that. Okay? All right. So this is it for chapter 9. We're going to take a quick little break, and then we're going to continue with chapter 7. Remember, once you finish with chapter 9, especially those of you watching this video I'm doing right now, you go and watch the video on range of motion. So for the rest of you in the classroom, stay in your seat. I will put on the video for range of motion. Okay? All right. Okay? I'm good. Wonderful. Take it. Okay. Mm-hmm. All right. Give me 1 second. I'll put this video on and then I'll talk. Okay. Oh.